Well, thank you very much. So, my talk next will cover benign focal liver lesions. That is a huge challenge because there's so many, and it is partly a little bit of difficult. So, let me start first of all. We're very happy that the Americans are joining now the contrast family. I think it's now 4 or 5 years weeks ago that Lumason, that is the name for Sonovy in the US, has now been approved by the FDA in the US. So that is, of course, a huge step forward. So as Barry Goldberg said once, the US is the third world country in regards of the contrast agents, so that is no longer true because they are joining us. So most common benign hepatic tumors and pseudotumors. Number one is, of course, focal fatty changes. This is very often finding cysts, hemangiomas, and I will cover in my talk the most common benign lesions. So I will cover the hemangiomas, typical and atypical ones, the FNH, typical, atypical, infectious disease, very small one, just have only one example for that. Adenoma and the classification of adenomas, that is a huge discussion point among not only the ultrasound specialists. Lipoma, AML, granulomas, biliary adenomas, mucinous cyst adenomas, inflammatory pseudotumor, and porphyria cutanea, they may have these echogenic lesions in the liver that enhance just like the liver, so you don't see any difference, or you cannot really characterize it by contrast. So I will not cover these ones, but let me start with the typical hemangiomas. You already heard that you have a peripheral nodular enhancement during the arterial phase, a progressive centripetal filling starting in these peripheral nodules to a partial or complete fill-in, and you have an enhancement that is sustained through the late and the post-vascular phase. And Sears makes an accurate diagnosis in 95% of the cases and a specificity of close to 100%. Why is it only 95%? Because some of the hemangiomas, mostly those that have a medium size or very small, they are completely thrombosed. So this is the challenge for, I think, all imaging modalities. So let me start with this case. You see two typical hemangiomas in grayscale. What is typical? Typical is this echogenic rim around it. You do not see it all the time, but if you see it, that is highly suggestive of an adenoma, of a hemangioma. You also see a posterior enhancement. And when you give contrast, have in mind, please, that all hemangiomas are supplied by arteries. So the arteries, they push the blood into the small lacunas of a hemangioma. So what you can see here is when the loop is running again, I can show you. Here are the small nodules here that are filled with blood and contrast. But if the loop is running again, you can see this is the artery. So you see the enhancement only in the artery. There's no portal vein. Now the portal vein is coming. So hemangiomas are supplied by arteries. And you can see that the best modality to see and demonstrate that is contrast-enhanced ultrasound. And of course, if you wait a little bit longer, then you can see the hemangiomas are nearly completely filled. This is after 1 minute, so this is not the challenge. Okay, and of course, hemangiomas might grow. So very often we get patients who have a hemangioma that was diagnosed previously, and then they are referred again because the hemangioma has grown. Of course, hemangiomas might grow, and there's a nice study by Yeague published in 2007, and they found out that around about 7 to 8% of hemangiomas grow in size. What is the diagnostic confidence of B-mode imaging of liver hemangiomas? Because when I started to do contrast on hemangiomas, very well-known colleagues in ultrasound came to me and said, well, come on, you're joking. You do not need contrast for hemangiomas. So this is such an easy diagnosis. And they are correct, but only if you look at patients who have a very low risk for a malignant disease. So healthy patients, incidentally finding of a hemangioma, and it looks typically like a hemangioma. They have no laboratory findings that point to another disease, so they are healthy subjects. So if you find in a healthy subject a lesion that looks like a hemangioma, it is a hemangioma. But if you have a hemangioma in a population at risk, then the number drops down to 50%. Only 50% of those who look like hemangiomas are hemangiomas in patients who have a chronic hepatitis B, C, or who have a history of malignancy. So that is important to have in mind. Atypical hemangiomas, and I'm concentrating more on the atypical ones because the typical ones are so typical that I will not cover more cases of that. So they are mostly echo poor. And the question behind it is, do we have a fatty liver disease? Because in fatty liver diseases, mostly all or nearly all liver lesions look echo poor. We have sclerosing tissue, calcification, hemorrhage in atypical hemangiomas. They might be completely thrombosed. They are hard on elastography. They have a centrifugal filling of contrast. That is very rare, but you can see that. You have shunting and you have washout. Okay, so this is another case of a 23-year-old male who came with a tumor of the testicular tumor, highly malignant, and he came with this lesion in the liver, and that was, of course, a hemangioma. But then he received chemotherapy, and under chemotherapy, the liver experienced fatty changes. And due to the fatty liver disease that he now has under 3 courses of chemotherapy, the hemangioma looks like something else, but it doesn't look any typical more for a hemangioma. But of course, it's still the same. Let me show you this case here. This is a Turkish lady, 52 years old, and she has 3 echo poor lesions in a slightly fatty liver disease. So the first idea, of course, was where is the biopsy needle? But first of all, we do contrast. And of course, in contrast, surprise, this is a typical hemangioma with a peripheral nodular enhancement. And when we look later, nearly completely filled. So there's no discussion about that. You don't need any other imaging modality. You don't need biopsy, nothing. So that's it. Diagnosis confirmed. What about this case? This is a patient with a colon cancer. And he had a lesion in segment 7 with a central calcification. And again, we were looking now for elastography, and it looks like a heart tumor. Then we look for contrast, and in contrast, again, you can see typical hemangioma. No question about that. And here's the late phase. You see it's a progressive centripetal filling. This is another case. So this is looks like a typical hemangioma. When you look at the early arterial phase, then you can see that the enhancement starts in the center of the tumor. So we have a centrifugal filling of this hemangioma. And here is an FNH. So we have an FNH plus a hemangioma. So we wait a little bit. So this is after 1 minute, and then you can see a progressive filling. We again wait a little bit, and it proceeds to the periphery. And then after 2 minutes, completely filled, and it's hypervascularized. Okay, so this is a patient who was in another hospital, and it was suspicious, this lesion. So they said we biopsied. They did 3 biopsy, fine needle biopsy, and all the biopsies showed no pathology. So then the patient was really upset about that, and he left the hospital, came to our place, and we were looking at this lesion and found out it is really not typical. So this is the arterial phase. You can see that the contrast is arriving. So here is the enhancement, and it's dominantly in the periphery. It's enhancing. But also in the center, you can see some enhancement. So we wait, and this is after 1 minute, and then you can see the periphery looks like it's washing out, and the center is taking up contrast. So now we are at 2 minutes, so it's washed out. So we biopsied that with the core biopsy, and the core biopsy said this is a sclerosed hemangioma. This is not easy to make this diagnosis, and I must say from today, and when I review this case, I would say I would do it again to biopsy this lesion. So it was not easy. So this is another typical hemangioma, and it is filling very, very quickly, within seconds, a few seconds. So this is a high-flow hemangioma, or a very quick fill-in hemangioma. And what you can also see is some shunting. You can see the shunting. You can see a wedge-shaped shunting. Just like I showed you before in this malignant tumor of the liver, there was also some shunting. But here also shunt of these hemangiomas. So that is not a rare finding, so you can see that quite often in hemangiomas, if you look very carefully during the arterial phase. And this is later, of course, during the late phase, or this is the late portal venous phase, you don't see any enhancement. Okay, so this is again the still frame from this arterial phase after 22 seconds. Okay, this is another lesion in segment 5. What is special about it is here's a lesion, and then you can see a wedge-shaped hypoechoic area developing here along the portal venous tract. So what is that? So we did color Doppler. So color Doppler is sometimes very helpful. So we do that all the time. But in this case, what you can see immediately is that there is a reverse flow in the portal vein. So we have the artery with the correct flow direction and the portal vein flowing backwards. So there must be a lesion with shunts. So the question is, what kind of lesion is that? So we give contrast. So we give contrast, and you can see two hemangiomas, two classical hemangiomas, peripheral enhancement. We followed this lesion until the late phase, and it was completely filled. And this is again a accumulation mode. You can see quite nicely here the supplying artery. I'll show you. This is the supplying artery of the hemangioma. So this is what the Wolfram guidelines said. So we already heard from David about the criteria that have been written down in the Wolfram and EFSUM guidelines. Some tips and tricks. Number one, consider that an echogenic lesion in a Seus mode may not be cancelled out completely. So when you have a really very outstanding hyperechoic lesion, and then you switch to contrast mode, so maybe the lesion is not cancelled out, so it stays there. And when you give contrast, and you see that the contrast is being washed out over time, then of course the hyperechoic lesion stays in the image. So that is something that you have to have in mind, and a TIC technique may help to see if it's really washing out to the level before contrast injecting. Do not scan continuously in one scan plane. So I think this is one of the most important points, because then you destroy bubbles. And the longer you scan, the more bubbles you destroy. And then it looks like that the lesion has been washed out. But that is artificial, that is due to your scanning technique. So don't do that. As soon as you have realized, yes, we have a peripheral nodular enhancement, stop scanning. Wait a bit, and then scan again, and then you can see a progressive. Do not scan and say, oh, I need to record it over 5 minutes. Don't do that, so then you have hemangiomas that look different and not like hemangiomas. Carefully watch the fill-in of small peripheral nodules, even when they are very small, because some hemangiomas are thrombosed, partly thrombosed, so maybe you only see these peripheral nodules being early enhanced. So this is sufficient to make the diagnosis of a hemangioma. So be very careful in looking for these peripheral nodules. No contrast uptake at any time in completely thrombosed hemangiomas are a challenge. The ones that we have seen, they all went to CT, and on the CT or MRI, they said highly suspicious for metastasis because they never take up contrast. So when we look at these lesions and we saw no contrast uptake, the histology proved that it was a completely thrombosed hemangiomas. I'm not saying that this is really a proof, but it's highly suggestive of benign lesion. Okay, liver abscess, of course, it's an easy diagnosis. This is a patient who had a liver abscess. He had received drainage, and after that, again, he developed fever and pain in his epigastrium. So here you can see it is again, a recurrence of these abscess, and you can see the peripheral hyperenhancement around these abscess. So this is typical, like in any other imaging modality. So that is not a challenge, I think, for any modality that you use. FNH, it is the second most common benign solid tumor. It is a result of a hyperplastic response of hepatocytes to the presence of a pre-existing vascular malformation. So there is an old story that says, okay, if you take any hormones then young women should not use contraceptives anymore if the FNH has been diagnosed. That is not true. It's only true for adenomas, but not for FNHs. On ultrasound, solary in 2/3 of the cases, mostly round-shaped, echogenic to echo-poor. They have a central scars, so this is, or the central scars being missed in 30% of the cases. So the ratio between male and female is, or female to male, 5:1 to 9:1. Hard on elastography, so this is an important feature to differentiate it from other tumors. Color Doppler, we see the spoke and wheel sign, and in CIUS we see a tumor supplied by a central or peripheral artery or arteries, more than one, a corkscrew-like tumor-supplying artery, but this is of course not specific. You can see that also in other tumors that are hypervascularized. Spoke and wheel sign arteries not accompanied by portal veins, a centrifugal enhancement causing a quick growth of the lesion. So if you give the contrast and you have a high temporal resolution, then you can see the tumor starts in the center and then it's growing within seconds. So that is typical for FNH. Iso to hyperenhancement until the late phase and the central scar and arterial portal shunting may be seen. So this is an example of an FNH of 8 centimeters, and you can see during the arterial phase, the wash-in, this is again a accumulation image. You can see quite nicely this is your supplying artery, the vasculature, but you can see the vasculature better if you not using this technique, but if we switch to B-flow with contrast. B-flow with contrast means we have a subtraction technique, and due to subtraction technique, you will not see the stationary echoes. You only see bubbles that are moving. I show you how that looks like. It looks like that. You only see the vessels. And what you can see is not only one, but you can see multiple stellate pattern of arteries. At least you can see 3. I have no pointer here. It's not working. But I think you can see it quite nicely in the center, then left to the center and above. Another case, again, contrast is coming, and the quality of a contrast setting can be seen in a FNH because the central scar is always there. Most images that you can see you can see the central scar only in the portal venous phase or the late phase, but it should be there, of course, also in the arterial phase. And that is something that demonstrates that the spatial resolution and the contrast resolution is so good. Like here, this is the central scar, and it's also being seen during the arterial phase. Contrast is coming, and here is the central scar. Very nice to see during the arterial phase. We have 18 seconds now, and we can see it already. This is a male, also male patients have FNHs. And this is with a 9 megahertz linear probe. You can see the arteries. They have a higher concentration of bubbles in the beginning. And you can see the stellate pattern of the vasculature in the, or the vessel morphology in the FNH. Very nice to see, I think, and it's growing over time. Okay, so this is another patient also with 2 FNHs, and we are looking for the one that is not easy to see. It is located in segment 7. It is here. And when we give contrast, and we do a sweep over these lesions, then you can see the supplying artery. tortuous artery. You can see the internal vasculature of the tumor. And then we can have also an endless loop running, like here. So typical FNH, and we know this FNH now since a couple of years. It's not growing, and it stays the same. And these are the FSIM guidelines, and David again already mentioned the typical features of a FNH in his talk. Now we come to a most challenging part of the talk. These are the hepatocellular adenomas. There's a low incidence, 3 to 4 in 100,000 people in Europe and America. It's lower in Asia, and 85% young women are affected. HCA rare in children, male and in the elderly. The risk factors are in female, estrogenic steroids and androgenic. So these are the males who go for workups, so they try to get more muscle, so then they have androids. And if they have these drugs, if they take these drugs, the risk of developing adenomas is higher. So 80% we see patients with contraceptives. The incidence is increasing in patients with type 1 glycogen storage disease and hemochromatosis. Solitary in 70 to 80%, multiple in 20 to 30. Hemorrhage may occur, and that may be life-threatening even. And it is especially can be expected in adenomas exceeding 5 centimeters. Malignant transformation, that is always a discussion, to HCC in 4 to 7% only. But the risk depends on the genetic type, and this is where the story starts. We have 4 different types of adenomas. We have the inflammatory HCA, 30 to 50%, some mutations, so it is a genetic description how these subtypes look like. Then we have the HNF1 alpha inactivated HCA, this is 30 to 35%. Then we have the beta-catenin mutated HCA, 10 to 15%, and we have the unclassified ones. Is that important? Well, it is important in that term that only the beta-catenin mutated HCA, they have the highest level of transformation into malignant tumors. So this is why we should try to classify these. And the HNF1 alpha, they have a very good prognosis, and the inflammatory HCA have 10% risk of malignant transformation. So we start with the inflammatory HCA. This is the biggest group. It is the most common subtype, most in young women with oral contraceptive. It is more often seen in fatty livers, and the inflammatory infiltrates and hemorrhage can be found in 30%. And 10% malignant transformation, formerly known as teleangioectatic FNHs. So this term should no longer be used as most of the authors state. Inflammatory HCA can mimic FNH on MRI. Conventional pathology using histopathology alone may lead to misclassification. And this again is an important point, because it very much depends on who is looking at the histology. So it is, I also have to say that not every pathologist believes in this new classification coming from Bordeaux. So some of the pathologists still think the old way how to classify adenomas is still working and it's sufficient. But now when you look into literature, I think nearly all the papers being published in the recent years, they all refer to this new classification from Bordeaux. And then we have these HNF1 alpha inactivated HCA, second most common one and least aggressive subtype, only in women with oral contraceptiva, multiple in about 50% of cases, prominent tumor steatosis. So this is important. The tumor steatosis you can see because on grayscale they are hyperechoic lesions. And the beta-catenin mutated HCA, they have the highest risk of malignant transformation and more frequent in men. Contrast features from hypo to hyperechogene, mostly sharp margins. In most cases, they are soft on elastography. Of course, if it starts bleeding, they are no longer soft. They may have they may become hard on elastography, but in the far most cases, it is soft, and therefore elastography may play a role in distinguishing adenomas from FNHs. Early but less enhancement in the arterial phase when compared to the FNH, no portal venous supply. That may be one of the reasons for a washout. Centripetal filling, so there's an important, maybe a different, important difference to the FNH, although FNHs that are supplied by arteries that arise from the periphery may mimic also a centripetal filling. In up to 30%, they are encapsulated. So that is what the pathologists are telling us. With a non-enhancing rim in the arterial phase, later they are iso-enhanced. That is important, I will show you later. So this is a patient, histologically proven inflammatory HCA. You have two encapsulated adenomas. So this is color Doppler. You can see here quite nicely, this is the adenoma. This is one. And I have to admit, I didn't see that before. But you will see that later on contrast, the second one. Okay, now the contrast is coming, and when you look at the filling type, it comes more from the periphery and is filling the center. Here you can see the capsule. And here's the second one, also with a capsule. And this is, of course, again, a finding that you can only see when you have a very high spatial resolution contrast setting. Otherwise, you will miss this capsule. Again, here's the second one. And this is later. Of course, after 1 minute, it's gone. There's no capsule anymore. Because the capsule is not a non-viable tissue, it's also viable tissue, so it's taken up contrast over time, but not in the arterial phase. This is a hepatocellular adenoma. This is the HNF1 alpha inactivated HCA. Okay, it's fatty liver, it's fatty tissue. And when you look at the contrast, it's taken up contrast, but over time, it starts to wash out. This is another one. Also, you can see on grayscale already that there is a encapsulated lesion, and you can see it much better on contrast. So there is another hepatic cellular adenoma. These are the guidelines. They are not very specific because, as I just explained, there are multiple criteria that you have to look for in adenomas. So this is why it's always a challenge to make the diagnosis of an adenoma. So that's what I wanted to tell you about benign lesions. I know there are many more benign lesions, and I didn't have enough time to cover others, but hopefully these are the most important ones, I think. Thank you very much.